Risk stratification for common bile duct stones. Welcome to our deep dive on risk stratification for common bile duct stones, a subject every surgical resident should feel confident navigating. Today, we will walk through the key principles, clinical scenarios, and management strategies that underpin the rational and evidence-based approach to common bile duct stones. Let us begin by understanding the primary aim of risk stratification in this context. The goal is to anticipate, with reasonable accuracy, the likelihood that a patient harbors a common bile duct stone before proceeding with any intervention. This careful prediction is not just academic, it is crucial in clinical practice because it helps us avoid subjecting low-risk patients to unnecessary, invasive, and expensive procedures. At the same time, it equips us to plan the best possible management for those at intermediate or high risk, whether that means selecting specific imaging modalities or timing procedures appropriately. The most widely employed framework divides patients into three categories: low risk, intermediate risk, and high risk. Let us walk through each group in detail. First, consider the high-risk patient. These individuals have more than a 50% probability of harboring a common bile duct stone. The classic clinical scenarios include someone with a stone visualized directly on imaging, such as a transabdominal ultrasound, a computed tomography scan, or magnetic resonance cholangiopancreatography. Symptoms of ascending cholangitis, right upper quadrant pain, fever, and jaundice are especially telling, with the more severe Reynolds pentad, which adds hypotension and altered mental status signaling septic shock. Laboratory findings may reveal a total bilirubin greater than 4 mg per deciliter, and this value is even more predictive when combined with a dilated common bile duct seen on imaging. Severe gallstone pancreatitis, when a gallstone blocks the ampulla, also places a patient in this high-risk category. In these cases, the recommended management is usually preoperative endoscopic retrograde cholangiopancreatography to extract the stone and relieve the bile duct obstruction before any further surgical intervention. In situations where the patient is unstable and suffering from severe cholangitis, urgent biliary drainage, either by endoscopic retrograde cholangiopancreatography or percutaneous transhepatic cholangiography, can be life-saving. Let us now move to the intermediate risk group, comprising patients with a 10 to 50% likelihood of a common bile duct stone. These are often the most challenging cases, as there is suspicion but no definitive proof. Several factors increase suspicion. A dilated common bile duct on ultrasound, for example, more than 6 mm in patients under 50, more than 8 mm in those aged 50 to 75, and more than 10 mm in those older than 75. Mild to moderate elevations in total bilirubin, abnormal liver function tests such as elevated alkaline phosphatase or gamma-glutamyl transferase, and a history of jaundice or pancreatitis. The presence of multiple small gallstones, less than 5 mm in diameter, should also heighten concern since these are more likely to migrate into the common bile duct. Management for these patients is nuanced and must be individualized. Non-invasive imaging with magnetic resonance cholangiopancreatography is often preferred to confirm or rule out the presence of a stone. Alternatively, an intraoperative cholangiogram can be performed during laparoscopic cholecystectomy, where dye is injected to outline the biliary tree. If a stone is discovered, the surgeon may proceed with a laparoscopic exploration of the common bile duct or arrange for postoperative endoscopic retrograde cholangiopancreatography. In select cases, where clinical suspicion is particularly high, preoperative endoscopic retrograde cholangiopancreatography may still be appropriate. Finally, let us discuss the low-risk patient. In this scenario, the probability of a common bile duct stone is less than 10%. These are individuals with symptomatic gallstones but no clinical or biochemical evidence of bile duct obstruction. Predictors of low risk include completely normal liver function tests, no history of jaundice or pancreatitis, a common bile duct of normal diameter for the patient's age, and absence of clinical cholangitis. For these patients, the best course of action is to proceed directly to laparoscopic cholecystectomy without further imaging or testing of the common bile duct. As the likelihood of finding a stone is exceedingly small, it is important to remember that risk stratification is not a static process. Patients can move from low to intermediate or high risk if their clinical status or laboratory values change during observation. Clinical judgment remains paramount. Guidelines are tools to support, not to replace, the thoughtful and experienced clinician. For example, a A frail older adult with a dilated common bile duct and an upward trending bilirubin, even if not quite at the high-risk threshold, may still warrant more aggressive investigation and management. These approaches are grounded in the 2010 guidelines from the American Society for Gastrointestinal Endoscopy, a robust and evidence-based framework for clinical decision-making. Additionally, endoscopic ultrasound is emerging as a highly sensitive alternative to magnetic resonance cholangiopancreatography, especially in cases where magnetic resonance imaging is contraindicated or inconclusive. While endoscopic ultrasound is more invasive, it avoids the use of radiation and provides excellent diagnostic information. To sum up, accurate risk stratification for common bile duct stones advances patient care by ensuring that individuals receive the most appropriate, timely, and targeted interventions, while minimizing unnecessary risks and costs. Thank you for tuning into this podcast discussion. We hope this breakdown enhances your understanding and confidence as you manage patients with suspected common bile duct stones. If you enjoy the content, please like, share, and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.